Hello everyone, welcome to my presentation. Today I'm actually going to present my last article. I have presented 5 articles before this one, and this is called Hospital Strategies for Reducing Emergency Department Crowding, a Mixed Method Study. And if we are to briefly mention about this article, there are actually multiple authors, but the main one is actually Anna Mary Chang. And this article has been published in the Annals of Emergency Medicine, an international journal, volume 71 and issue 4. And it has been published in August 25th, 2017. And this study actually has been conducted between January 2015 and June 2016. So if we are to briefly mention the study objective is, emergency department crowding is leading to patient dissatisfaction, and besides that, it's actually increasing the number of deaths. There are more than 130 million emergency department visits annually, and it seems like this problem is going to only increase day by day. And the negative effects of emergency department crowding on public health will continue to intensify because of this matter. However, although there is a decade of operations research in this topic, the strategies to reduce emergency department crowding are actually yet to solve this problem. But what are the motives of this study? There actually has no systematic efforts to study hospitals with different levels of performance, and the majority of previous studies have evaluated single interventions at single sites. There is limited understanding of the influence that critical organizational characteristics play on emergency department performance because these variables are difficult to measure and are rarely studied. Most studies have focused on processes within the emergency department, but failed to examine root causes of emergency department crowding, such as lack of inpatient beds, which actually might be outside of the emergency department's control. So actually the editors has provided a little bit of a capsule summary, so it will actually give a better view of this article, so I would like to mention that. And they have differed all these parts. First of all, what are we know about this topic? We know that emergency department crowding and patient boarding are persistent problems despite decades of effort, as I've mentioned before. What questions this study addressed? This qualitative study compared organizational characteristics of 12 emergency departments with low, high, and improving performance on length of stay and boarding metrics to identify those associated with better performance. What this study adds to our knowledge? Well, 4 organizational properties were associated with better performing emergency departments: senior executive involvement, hospital-wide strategies, data-driven management, and performance accountability. No specific interventions were clearly associated with better performance. But how is this relevant to clinical practice, you may ask? Better performance on crowding and length of stay measures is associated with broad organization characteristics, but not specific implementation mechanisms. So they have tried to identify effective organizational practice to reduce emergency department crowding using a positive deviance approach. They use quantitative data to define a sample of high and low performing hospitals on measures of emergency department crowding. Then they applied quality methods, semi-structured interviews with hospital leaders and staff to elucidate the complex organizational factors such as work processes, social interactions, organizational cultures, norms, and so on, and that distinguish high and low performing hospitals. They have analyzed interviews from a separate group of high improver hospitals to validate these findings. So what are the materials and methods? Like how did they conduct this study? It's basically in this mixed method studies, quantitative methods were used to identify the hospitals with high performance, low performance, and highest improvement in emergency department lengths of stay for admitted patients, and then sampled from these groups of hospitals for detailed interviews. Samples from a national cohort of hospitals in that participate in Centers for Medicare and Medicaid Services, which is shortened as CMS, reporting program for emergency department timelines metrics. These three types of hospitals mentioned in the study have a rate according to their case mix adjust performance in 2012 and 2013. Sample hospitals were selected to represent diversity in characteristics that might affect strategies to reduce emergency department crowding within each stratum. So they were really mixed, like urban and rural. It didn't really actually matter. The more diversity, the better for the study. And when requesting study participation, they did not disclose performance status. They have asked the initial set of interviews at each hospital to suggest additional key informants within their organization, such as administrative leadership of the hospital and people who are part of crowding and hospital flow task forces. And how are these interviews have been conducted? Well, actually, they have been conducted by telephone with key hospital informants and with an average of 5 interviews per hospital. The semi-structured interview guide was pilot tested within the hospital leadership and crowding committee experts, and then iteratively refined during the course of the study. Interviews averaged around an hour long, and they were out of tape and they were professionally transcribed. The primary data analysis in this research, an open coding approach that involves examining the data to identify them, has been applied. The codes were then grouped into higher order categories. Analysis and coding of additional transcripts from new interviews were compared with previously coded data. And the mentioned software to facilitate review, analysis, and reporting of the data is Atlas.ta, which is actually a software. And the process of data collection, coding, and constant comparison has continued until there are no new concepts to be identified. Then those mentioned concepts were sorted, named, and grouped. So here we can actually see this is the table 1 in this article, and this describes the characteristics of 12 participating hospitals. Emergency department length of stay worsened from 2012 to 2013 for one of the 4 high-performance hospitals, as we can see from this graph. And rankings were stable for all low-performance hospitals. High-improving hospitals, however, demonstrated 14% to 58 absolute percentile rank increases on emergency department timelines measures between 2012 and 2013. So we can say low performance have stayed the same, but improving and high performance have actually increased. So what are the conclusions drawn from the interviews? Well, 60 staff members have been interviewed during the study, and interviews from all types of hospital had a shared theoretical model of emergency department crowding. The lack of inpatient beds, this position led to boarding of admitted patients in emergency department. Inpatient boarding reduced the effective capacity of the emergency department to evaluate and treat new patients, which in turn led to emergency department crowding. So with this understanding, hospitals across all strata address performance by using both within emergency department and hospital-wide interventions to reduce crowding. Rather than the selection of strategies, interviews stressed that the difference was in how the organization supported the execution of the strategy. So here is actually a quote from the table. I'm going to show the table to you, but first I would like to give an example. So rather than determining approaches, the interview stressed that the distinction was how the organization supported the execution of the strategy. So emergency department chair of hospital 3 actually have coded, I think the biggest challenge is the execution, and in many areas the execution has not gone forward. Whether there is not a champion or the person who is championing, it is not pushing hard enough, or there is no incentives or disincentive, really no carrot, no stick to try to make things go. So actually they were they were trying to show that their execution has not going forward, and they're not really trying to make things better. So this is the table 4. I know it's kind of blurry, it's kind of hard to see, but this is like, I'm going to explain each segment of this table, so it will be a little bit more clear. And basically, 4 broad domains characterize and differentiated participants' experiences in study hospitals, executive leadership involvement, hospital-wide coordinated strategies, data-driven management, performance accountability. Also, these have separated inside as we can see here, high, improver, and low. So basically, we can say that this table contains additional codes for each domain labeled by the hospital performance level. In high-performing hospitals, executive leaders identified hospital crowding as top priority. Yeah, this will be better for this slide. For example, in Hospital 2, the Chief Executive Officer made a clearly defined target metric. 80% of emergency department patients will be admitted or discharged within 3 hours. Executive leadership took an active role in reducing hospital crowding in high-performing hospitals. In low-performing hospitals, executive leadership did not prioritize crowding initiatives despite acknowledging the causes. High-performing hospitals consistently adopted cross-departmental initiatives. Laboratory services, hospitality, surgery, housekeeping to alleviate crowding, and low-performing hospitals rarely did that. Similarly, high-improver hospitals show a similar pattern of adopting interdepartmental strategies that address each step of patient flow. In contrast, low-performing hospitals reported lack of buy-in for hospital-wide coordinated strategies. High-performing hospitals proactively used data to reduce emergency department crowding. Data were used in specific ways, changing behavior and plans real-time, providing feedback to personnel on specific cases, and predicting patterns of emergency department and hospital flow, and matching resources to meet the needs of the hospital. And high-improving hospitals are reported that part of their improvement process included learning to report, collect, and use the data in efforts to improve emergency department crowding. And one of them actually said, this is from Hospital 11, and this is coming from a nursing director. We actually have 3 computer screens in our hallway back by our break room that have data on there for our staff to see. So we like to be transparent. We like to be data-driven. However, low-performing hospitals, data were most often available only retrospectively. And if the data were used, they were discussed by executive leaderships at only like monthly or quarterly meetings. High-performing hospitals had executive leaderships who engaged staff across departmentals and service lines to affect crowding metrics. These hospitals relied on constant communication and active management. For example, nursing leadership from Hospital 4 followed up with nurses the next day on cases which there were delays in inpatient admissions to delineate causes and possible solutions. This pattern was found in high improver hospitals as well. In contrast, low-performing hospitals often had services and departments that were isolated from the others and did not have accountability for throughput from the emergency department. There's actually a quote also. There was a lack of disposition on the admitted side. This is coming from Hospital 3, and it's coming from a nursing director, actually. This is from a low improvement hospital. So there are actually a couple of limitations in the study. One of them is delay, and the delay is actually the performance groups were defined according to 2012 and to 2013 from the CMS, but it is possible that those rankings may not reflect the current performance anymore. And senior executives were not interviewed in many low-performing hospitals. and this might be potentially not participating because they know their low performance. So in conclusion, high performance on emergency department crowding indicators is associated with specific organizational characteristics, including involvement of executive leadership, widely organized hospital strategies, data-driven management, and accountability of performance. However, different types of interventions do not appear to be associated with hospital performance. Rather, it's the interplay of organizational characteristics that makes for successful implementation of strategies. Thank you so much for listening.